Good evening, my dear students. So again, like every Friday, I am with you. But from now onwards, I will try to discuss more of the clinical cases. Okay. Because if you see,
Good evening, my dear students.
MBBS,
So again,
previous paper, you will see a lot of clinical cases. So how to approach? So sometimes even after knowing the theory part, we are not able to solve their questions that clinical. Every Friday and Monday, we will be discussing a lot of clinical cases. So today, question number one, clinical case number one, how to approach? A 45-year-old man present to the physician clinic with complaint of epigastric pain. After a thorough workup, the patient is diagnosed with peptic ulcer disease. Peptic ulcer disease, okay? He is started on a medication that is going to inhibit proton pump of the stomach. You know, PPI, proton pump inhibitors are given, like omeprazole, pantoprazole. These are proton pump inhibitors. Okay, this will be discussed more in GIT, but also in general physiology about the pump and all. So question is about general. What is the proton pump that is referred to? So this is not the GIT, this is the general physiology. So question might look like a GIT question, but now coming to the pump, like primary active, secondary active, okay, passive transport, triple diffusion. So this pump is called as proton pump. You all know about proton pump, I hope, primary active pump. So, what is the proton pump that is referred to? Question number one. Question number two, what type of cell membrane transport would this medication be blocking? Okay, so this is proton pump blocker. So, where is this proton pump which is blocked by this proton pump inhibitor? And what are four other types of transport across cell membrane? So, actually, this question is from general physiology, transport across cell. So question number one, what is proton pump that is referred? You know, proton potassium ATPase. This is primary active. Remember, there are two types of transport, active and passive. In the active, there are two again, primary active and secondary active. In primary active, if you remember, we always discuss mainly two pumps. One is sodium potassium ATPase pump, and second is proton. Third, also we have discussed SARCA, sarcoplasmic, endoplasmic, reticulum, calcium ATPase. So this proton potassium ATPase pump is actually an example of primary active transporter. It is not secondary active. But secondary active is like sodium glucose transporter, sodium amino acid transporter, sodium calcium exchange. So that is different thing. But they are asking about a drug which is blocking proton pump. That is proton potassium ATPase pump. Question number two, which type of pump it is? Answer is primary active transporter. See, if you know, you know. Clinical questions are like that only. If you know, you know. If you don't know, number is zero. Question number three, what are the other type of transport? Like simple diffusion, no use of ATP, restricted diffusion, okay, selective diffusion. Third is facilitated diffusion. Like, can you give example? Glut. Glut. Glucose transporter. It is a passive active transporter, but glucose transporter are carrier protein which are helping in the passive transport. So it is facilitated diffusion. Then secondary active transporter. It can be co-transporter, like if you remember the examples, SGLT, sodium glucose transporter, sodium amino acid transporter. Then we have counter transporter, if you remember. There are plenty of examples, like number one, sodium calcium exchanger. Sodium calcium exchanger. It is in the heart, it is in the kidney. Everywhere we will discuss this antibody. Okay, then there can be sodium proton exchange. You know everything. I'm just telling you how to approach this clinical question. If you see, they look like a JIT question, but this question from general physiology. Like that, second question, a 29-year-old woman seeks contraceptive. She has used barrier method and is considering the pill or injection. So before she might be using the barrier method, like condoms and all, but now she want to use some contraceptive. She reports poor medication adherence and frequent travel. She cannot take OCP. It has to be taken every day. So now, after counseling, she opts for medroxyprogesterone Depo-Provera and is advised to return in 3 months for next dose. So for 3 months, she can take one dose of Depo-Provera. Now this looks like a reproductive physiology question. Now coming to the question, how do injected hormones or hormone pills provide contraception? What is the mechanism of action of the hormone which is acting like a contraceptive pill or injection? At a cellular level, where is the receptor for progesterone blocked? Cell membrane or nucleus? Okay. Third, what is exocytosis? Three questions are asked. They are mainly from again general physiology. See, a 29-year-old woman desires hormonal contraceptive. What we have suggested, DIMPA injection. Mechanism of action of hormone is that when you give progesterone, what happens? Increased circulating progesterone causes negative feedback at the level of anterior pituitary. You must have read about the endocrine. So when you are giving progesterone injection, it will give negative feedback to whom? Anterior pituitary. Who is releasing FSH and LH? Because you know FSH and LH are gonadotropin hormone. Okay? And you know the whole physiology about that. Now, if there is an increased level of progesterone, what will happen? It will cause inhibition of FSH and LH surge. So it will not allow the LH surge. So ovulation will be inhibited and FSH will be less. So even oogenesis will be inhibited. So this is the mechanism to create negative feedback mechanism. Because you know, first table is hypothalamus. What is that? GnRH. Then pituitary gland, FSH and LH. And then comes your ovary. There are three level of controls. Now, if you give progesterone in large dose, it is going to emit FSH and LH. FSH is important for follicle growth and development. LH surge is important for ovulation, and both are inhibited. They will act like contraceptive. Second question, if you remember, there are two types of hormone receptor. One is cell membrane, like G protein coupled receptor and all. Other are cytoplasm and nucleus. They will act on the nucleus. You know, steroids are acting on the nucleus. Third, they are asked, what is exocytosis? It is a process by which contents within the circulatory vesicles are delivered to the extracellular fluid. This is about question number 2. Question number 3. See how simple they are. But once this will be discussed now, how to approach, you can get 100% marks because they are like pure concept. Either you know or you don't. Question number 3. A 5-year-old boy experiences transient limb weakness after exercise. After doing exercise, he's feeling weakness with banana intake. Banana means what? Potassium is more. Hyperkalemia. With muscle spasms and myotonia. Now, he is diagnosed with hyperkalemic periodic palsy. Hyperkalemic periodic palsy and advised dietary potassium restriction. So you must not take, more potassium like fruit juice and all, and glucose during attacks. Now, coming to the question. Question is from general physiology again. What is the effect of hyperkalemia on cell membrane potential? Resting membrane potential. I told you hyperkalemia so many times. Last time also I told you. Hyperkalemia decreases the RMP, hypokalemia increases the RMP. What is responsible for repolarizing phase of action potential? Third, what is effect of prolonged depolarization on skeletal muscle sodium channel? Now see, effect of hyperkalemia on RMP. RMP become less. It will be close to the threshold, causing depolarization. Why? Because I told you in hyperkalemia, RMP become less negative. So it can cause depolarization. Repolarization mechanism. What is the mechanism of repolarization? Activation of voltage gated potassium conductance and inactivation of sodium channel. So when will repolarization will start? Okay, opening of potassium channel and closure of sodium channel. What is the effect of prolonged depolarization? If there is a prolonged depolarization, and this process is called as accommodation. If you go to DocTutorial app and see the video, I have discussed this topic in very much detail. Hyperkalemia. It will cause inactivation of sodium channel. Okay, because RP is close to the threshold. So they will be in the absolute refractory period, causing inactivation of sodium channel. This is it for today. I will not exceed 10 minutes. I know your time is precious. So go open your app, look for more videos. Every Monday and Friday, I will be here for you just for short discussion. Till then, bye bye. Take care. All the best.